Hello, my name is Amanda Honebein, and this is my HE 380-01 Nutrition and Health presentation on factors around the rising prevalence of food allergies. So, what are food allergies? A food allergy is when the immune system holds a reaction after eating certain or specific types of food. This differs person to person as different people have different severities of their allergy. It can be onset or prolonged. When it's onset, it means the reaction occurs within 2 hours of digestion, but if it's prolonged, it means the reaction occurs within 4 to 28 hours of digestion. Food allergies affect 2.5% of the population and are described to be the increasing disease over time, as it's only just becoming more and more prevalent. Food allergies are derived from genetic and environmental factors, and that is how they affect the individual. The most common allergies are from egg, wheat, fish, nuts, and milk. With allergen exposures, if somebody has an extreme case, anaphylactic shock can occur from the smallest bit of an exposure. Anaphylactic shock will cause the blood pressure to drop and breathing passages to shut down within minutes. If it's a typical allergic reaction, the reaction to a food occurs within 4 hours after it has been eaten. Occasionally there is a delay of about 8 hours, but symptoms that occur a day or more after the exposure are rarely from an allergy. In this slide, I'm going to be talking about the past versus present history of food allergies. In this slide, I'm going to be talking about the history of food allergies. In 2735 BC, Chinese emperors Shen Nun and Huangdi provided advice concerning food. They said for pregnant women and people with skin lesions to avoid certain foods, for example, shrimp, chickens, and meats. They weren't exactly sure what allergies were at the time, they just noticed some individuals having issues and suffering from eating these types of foods. In 460 to 377 BC, Hippocrates was accredited with the first recognition of allergies. Granted, the Chinese emperors provided advice for it first, Hippocrates was the first to write about it. In his writings, he referred to the presence of hostile humors, which are now known as IgE antibodies, in some men, which made them suffer very badly following the ingestion of cheese, meaning that the consumption of cheese corresponded to the suffering, which then led to the discovery that allergies, which means it is a reaction caused by food. In 98 to 55 BC, Titus Lucretius Cato was quoted saying, "What is food to one, to another is rank poison," suggesting that not everybody was allergic to the same things and that different food items could harm different people in different ways. It strongly suggested an understanding of adverse reactions to foods over 2,000 years ago. In the 17th century, case reports of food hypersensitivity reactions began to appear in the medical literature. As it was becoming more prevalent, more people began writing about it. In 1906, Clemens von Pourquet coined the term allergy. During this time, many believed that food could trigger skin problems, asthma, gastrointestinal distress, and even mental disorders. In 1912 was the Prevalence experiment on the immunologic basis of food allergy reactions. In his experiment, he injected serum from a patient who was fish allergic and a non-allergic control into his own skin. Scientists were a lot riskier back then. On the next day, he injected fish extract into the exact same area as he did the day before, and noticed there was a reaction. This proves sensitivity could be transferred from an allergic to a non-allergic individual. And in 1921 was Schloss in diagnosis. Schloss introduced scratch testing. Scratch testing is a concept of using extracted protein from foods in the diagnosis of food allergies. In this slide, I'm going to be talking about the past versus present history of food allergies. In the early 1980s, the landscape of food allergy was very different from what it is today. Food allergies were less prevalent, and there was little public awareness of this problem. Most physicians were highly skeptical of the diagnosis, and there was little active research going on. This is primarily because many investigators did not consider the field to be a real science, unfortunately, which we still face today in some aspects. Skin testing was seen as being unreliable. In 1985, the prevalence of food allergy in the United States was similar to what is reported today, about 20%, but the actual prevalence then was thought to be less than 1%, compared to more recent estimates today of 3.5 to 5%. This just goes to show how unaware we were back then. The National Health Interview Survey in the United States stated the food allergy increase as a second wave of the allergy epidemic. Food allergic reactions were rare 35 years ago, but now represent the single leading cause of anaphylaxis treated in American emergency departments. Food allergies are still a question waiting to be answered. We also now have precise defining of what food allergies are and what does cause them. We also now have in vivo testing and gold standard food challenges, which I will discuss later on. So for some clinical aspect and management of food allergies have become a growing public health concern. Currently, the standard of care focuses on avoidance of trigger foods, education, and treatment of symptoms following accidental ingestions. Clinical history is the single most important tool a physician should use in the diagnosis of a patient. Because many patients may report symptoms related to food ingestion, charting food intake can distinguish food allergies from other food-related disorders. Food allergies are often mistakenly defined as any adverse reaction due to ingestion of specific foods or a type of food. A true food allergy is considered to affect the immune system, creating a reaction. If that doesn't happen, it is often labeled as something else. Here are some triggers. The 8 most common triggers of pediatric food allergens are peanut, cow's milk, shellfish, tree nuts, egg, finfish, wheat, and soy. Many do not know what exactly causes the reaction, therefore it is sometimes difficult to pinpoint. Cross-contamination is always a factor, as well as leading the possibility for some food products, primarily because of their location, to mix with one another. This commonly occurs in restaurants, bakeries, and buffets where the food is not confined and subjected to one area. Reactions are distinguished by onset. If it is rapid onset, it usually occurs within 2 hours of ingestion and typically resolves within 24 hours. While a majority of patients will have rapid symptoms that resolve relatively quickly, reoccurrence of symptoms within 72 hours of an initial reaction is probable, and an even smaller number of patients may develop refractory or persistent anaphylaxis from a reaction which requires resuscitation and inotropic support. It is very important to determine what foods a child is currently avoiding to pinpoint what exactly is causing a reaction. Physical examination of the patient should focus on the signs of an allergic reaction as well as other atropic disorders, commonly associated with food allergies. It may prove useful in distinguishing other specific conditions. Some clinical ways of testing for food allergies are using pediatric allergen-specific testing. This testing measures the presence of allergic antibody to a particular antigen. It is a blood test that can be performed at any age, but the controversy with this testing is the detection of the antibody by high sensitivity does not necessarily indicate an issue at all. We can also use skin prick testing. This is an in vivo assessment of mast cell activation, where a small amount of allergen is placed into the skin. Sensitized patients usually develop a wheal and flare reaction at the site of injection within minutes. This indicates that there is in fact an allergy. We can also use the oral food challenge. The double-blinded placebo-controlled food challenge is the gold standard for diagnosis of food allergy or confirming its persistence. This is performed by ingesting small amounts of a certain food in each day. In the photo I have on the top right, as it says, just add 1 drop of milk per day and keep persistently doing that until either you do see a reaction or if you can continue doing without a reaction. And once it reaches to a certain point, then you are safe to eat it and not have a reaction no longer. We can also use the elimination diet, which is sort of similar to what we said before, but, all foods in question are avoided for a week or so to see if allergic symptoms disappear with an elimination diet. When the foods are eaten again, one by one, you determine which are the issue. If this approach does not identify the culprit, a far stricter diet must be tried. So for some clinical resolutions and preventions to food allergies, the first thing to do would be receiving a prescription for medication of epinephrine. First-line treatment of anaphylaxis is always epinephrine. Second-line medications such as albuterol and antihistamines may also be prescribed for treatment of mild symptoms. But unlike epinephrine, they have no direct effort on the mast cells or basophils themselves causing that reaction. Prompt treatment with epinephrine is always encouraged as this may slow or halt progression of severe anaphylaxis. Most fatalities from food-induced anaphylaxis are associated with delayed administration of epinephrine. The next best thing to do is form an emergency plan. In case you ever have a reaction or your child has a reaction, you need to know what to do. It's crucial to be informed what to do because that makes the difference of living or dying. With knowing proper administration of your epinephrine and everything like that in every single detail, you have the best chance of survival. The most crucial thing to not getting a food allergy is avoidance. Strict avoidance of allergens is the only sure way to prevent food-induced reactions. Only small amounts of food can trigger acute reactions in highly sensitized people. This may vary considerably depending on the patient allergen, though. This can result in misdiagnosis or a false sense of security if small amounts of food can be ingested without symptoms. It is important to note that the severity of the food induced can affect your outcome. Some other ways of avoidance can be by reading food labels. In order to properly adhere to recommended elimination diets, patients and families should be instructed to pay careful attention to ingredient lists and foods with different contaminants and possible cross-contaminants. It is also crucial to be aware of your environment and what foods may be surrounding you. While most food-induced reactions occur in home, many families find that eating at a restaurant or a friend's home can be difficult because of your unawareness of what is going around. If a food allergy is suspected or diagnosed, it is best to be referred to an allergist. Allergists provide additional diagnostic testing and are equipped to manage anaphylaxis in the clinic. In addition to assisting with diagnosis, allergists can monitor and assess for the development of tolerance, as well as helping to manage the comorbid conditions such as atopic dermatitis and asthma that are commonly encountered in food allergic children. It is extremely crucial, and I will highlight the word crucial, that you go for a follow-up if you have an allergic reaction or any type of allergies. A specialist in allergy and immunology should see patients with food allergies at least annually and follow all the guidelines and all questions in any sort of detail that can be crucial to the future. For demographics, 32 million people in Americans have food allergies, 1 in 10 of them being adults and 1 of 13 being children, with children being the most at risk. This is primarily due to their atmospheres and where they are, such as being in school, you are exposed to so many allergens and different things everywhere. It is the most dangerous for a child to be if they have an allergy. African American children are most susceptible, and 15% of patients with food allergies are first diagnosed in adulthood, which is kind of crazy to think about, especially with it being more prevalent in children. 1 in 4 say they developed an allergy in adulthood also. 20-25% of epinephrine administration cases did not know of allergy that they had. Also, if somebody has asthma, they are at a lot higher risk. For some implications for public health, surveillance of patients' medical records and food intake history would help pinpoint exact sources of allergies. This would be extremely beneficial to people so they have more awareness of everything. The issue with food allergies, though, is it creates a huge financial burden on the family because some food items lack a substitution that will be equivalent in nutrition. It costs the United States $24.8 billion annually for food allergies, and children are at high risk. Limited information about food allergies may prevent new development of drugs. Because of the fact that when we go to the doctor so often, they often mislabel an allergy as just being a coincidence or things like that, really affects this. It also hinders the ability of individual work, causing a loss of human capital in the labor force. To help resolve food allergies, the best thing to do would be surveillance of patient medical records and food intake history, as I mentioned on the prior slide. It will help identify more causes, discover new allergies sooner, and bring awareness and prevention. What we need to do, though, is improve affordability, availability, and accessibility to all these resources and help individuals with food allergies. For some guidelines and recommendations, there are some put out by the Center for Disease Control. These are the voluntary guidelines for managing food allergies in schools and early care and education programs, hereafter called the Voluntary Guidelines for Managing Food Allergies. These guidelines were developed in response to Section 112 of the FDA Safety Modernization Act. The act is designed to improve food safety in the United States by shifting the focus from response to prevention. Parental obligation to provide the school or early documentation is part of this recommendation. It is best to give the school with documentation from their child's physician or nurse supporting a diagnosis of food allergy and any risk of anaphylaxis, and any history of their allergy whatsoever to help prevent or provide a reasoning in the future if an allergy reaction were to take place. It is also best for parents especially to create a plan for their child in case an emergency occurs. They should have a tailored food plan to their needs and to manage everything better, and also they should learn to administer the epinephrine themselves. Even though they are at such a young age, it is legal and not prohibited by law for children to inject themselves with it. Another recommendation is to have communication strategies in place between individual schools or early childhood education programs and providers of medical emergency services in case a reaction were to take place, and where exactly the child should go in case that does occur. Again, the best recommendation is avoidance. Avoiding any of the food in general, anything like that, will make it so you do not have a reaction, so it's best to avoid as much as you possibly can. Also, the CDC put out an allergy management prevention plan. This plan consists of 4 steps. The first is prepare for food allergy emergencies. Second is provide professional development on food allergies to staff members. In this slide, I'm going to discuss the controversy of oral immunotherapy for treating food allergies. It's very similar to allergy shots that work by desensitizing the immune response to certain triggers. And instead of injecting allergens through the skin, OIT, which is oral immunotherapy, involves consuming a bit of forbidden food each day at gradually increasing doses so the immune system can learn to put up a fight as well as the injections. Though this treatment is very beneficial, it is very contradicting and does not work for everyone. It is still best to avoid trigger food opposed to trying them. Many researchers dismiss the science of oral immunotherapy as thin and the treatment as unnecessary, as it's way too risky. Because of this, many insist that OIT is still experimental and needs further study to ensure it works consistently and safe. The main controversy that's part of oral immunotherapy is doctors and the medical fringe who diagnose allergies. On this fringe, they diagnose allergies on the basis of tests whose validity has not been proved. It is commonly seen among doctors who think something is an allergy to prescribe restrictive diets and costly vitamin and mineral supplements to everybody, every single patient, as a certain cure, when that's not the best remedy, as everybody has different allergies to different things. There is no exact agreement on how to categorize the various adverse reactions to foods or how to diagnose them for trained allergists, so it's easy to understand why many frustrated patients, after years of annoying visits to conventional allergists, end up turning to the medical fringe to identify the cause of their chronic or recurrent symptom. It also has been indicated in much research and studies that reactions that many doctors at first think are food allergies usually aren't, and they're just common sicknesses or convenient colds. The primary issue with oral immunotherapy is that it doesn't lead to a cure. It just temporarily desensitizes what is going on in the immune system, so it can't be affected by the allergen as severely. At the same time, though, oral immunotherapy can also cause more frequent allergic reactions. In a lot of cases, families may prefer their predictability over their rare surprise reactions that happens with avoidance. This kind of treatment varies from person to person. It's all more of a personal preference, as I just said, but it works for many, but some it doesn't work for at all. In early 2020, the FDA will reach a decision if oral immunotherapy will be a good way of treating allergies amongst foods. And the next controversy I'm going to talk about is how food allergy is considered to be a subcategory. The big question is why are more people experiencing severe food allergies than ever have before? In a recent investigation, it has been found that undeclared allergens were present in a quarter of food samples. That means these foods were not listed on the warning labels or on the food labels on the item to advise consumers of what exactly they are eating. Some allergies are not considered to be classical allergies because they do not directly involve the immune system. To describe the miscellaneous ill effects that can result from eating particular foods, physicians use words such as sensitivities, toxicities, intolerances, false food allergies, pharmacological reactions, and metabolic reactions. As I mentioned in this slide before, it is extremely controversial with how doctors label allergies, or often labeling something as an allergy when it isn't one, or not declaring something as an allergy when it is in fact one. A lot of people feel that physicians treat their allergy as being not as important because it does not hit the level of being an affectant on the immune system. Opposed to implementing more tests and everything like that, doctors just follow a routine diagnosis opposed to actually investigating into each person. The food allergy category needs a lot more attention and is undermined greatly. In this slide, I will talk about what is being done by individuals pertaining to the topic of food allergies. One thing a lot of people are doing is bringing awareness to this topic. Since so many people are affected by allergies from foods, they want more and more people to be educated upon the topic and know what to do in case an allergic reaction is near them or is about to take place to themselves. Awareness can be brought with support groups, awareness sessions at school, and also with ribbons. With having awareness sessions at school, especially because allergic reactions and things like that are more common in school-like settings due to the huge environment, education will offer a great opportunity for students and staff to learn about allergies and their importance. With the teal ribbon representing food allergies, anywhere the ribbon is seen will help bring awareness towards it and its prevalence. Another thing a lot of individuals do is offer support. They offer inspiration, support, understanding, and hope to someone whose child is newly diagnosed. Oftentimes, it's really detrimental to families and to parents when their children is diagnosed with a food allergy or has recently suffered an attack from a food allergy. The best thing to do is know that you are there for them and will help them through all steps of the way and answer any questions they may have. It is also best to advise them of the best guidelines to follow and plans to take in case an allergic attack happens again. Another thing a lot of families do is donate to allergy-free food. With donating allergy-free food, it'll help relieve the financial burden that many families face when their children have food allergies. Also, with donations, it helps with research for food allergies as well. Also, another amazing thing people are doing is sharing the resources. When they learn something new or find a new doctor that is actually helpful, they will pass that information on to others who may need it. Some disparities with this is that we still can't prevent allergic reactions with bringing awareness. Regardless if we bring awareness or not, unfortunately, people will still suffer from food allergies. But the best thing awareness could do is help prevent them from occurring more often. In this slide, I'm going to be talking about what is being done by the government for the topic of food allergies. The government's honestly not doing too much for the topic of food allergies, as it's only spending 19 cents per person on research. There still is no cure or treatment. The House of Representatives are currently considering a new bill, which I'm going to be talking about more in the next slide. But really, we are currently unsure of the outcome and if they're going to be accepting the bill or not. Some disparities to this, and with the government helping, it is that it will cost more money. And especially in the government's eyes, anything that costs money is looked at as a bad thing. I definitely think the government should focus on putting more research and money into food allergies, as it's killing so many people daily that if we find a cure to it, it can save millions of lives. On this slide, I'm going to be talking about what is being done by organizations pertaining to the topic of food allergies. The Food Allergies Safety, Treatment, Education, and Research Act, the FASTER Act, believes that additional research is crucial for finding the cure and treatment for food allergies. The FASTER Act is trying to update allergen labeling laws to include sesame. It would also require updating labeling for new allergens as specific scientific evidence emerges. These new updates would be part of the new U.S. House of Representatives bill. In order for this bill to pass, there needs to be as many legislators as possible to co-sponsor the bill in the coming days. Also within the bill, it will be required that the federal government to gather comprehensive nationwide data about the incidence and growth rates of many different types of food allergies as well. This will also help prevent and find a cure for the allergies. Some disparities with this is many may not want to co-sponsor or fund the organization because a lot of people like to see where their money is going, and unfortunately, if this bill is not passed, a lot of people may be frustrated. But if you would like to click the link I put on the slide right here, you can sign up as a co-sponsor. It doesn't cost anything. It's just another signature basically to say that you support the FASTER Act. Hopefully, if this act passes and this bill is signed, then we can help prevent allergies from becoming worse. In this slide, I'm going to give a brief summary of what we talked over today. The first thing I'm going to be talking about is the prevalence of food allergies, and how 32 million people suffer from food allergies. And the most common allergies are from egg, wheat, fish, nuts, and are derived from genetic and environmental factors. The next key point I'm going to talk about is avoidance. Avoidance is the best recommendation for prevention. If you avoid the allergen, then you're more likely than not going to have a reaction to it. You just really need to be careful and aware of everything you're doing and where you are at all times. Key points from the controversy we talked about. Autoimmune therapy offers hope, but it's not accessible for everyone and can be quite expensive. Hopefully when the FDA, if they approve the therapy in 2020, it will offer a better option for those who can afford it. But unfortunately, many probably will not be able to afford it unless it is covered by insurance, which hopefully it will be, but chances are it will not be. Another controversy we talked about is that food allergies are almost being overlooked. Nothing that can kill you should be overlooked at all, and that needs to change. And the next key point I would hope everybody took from this is awareness. The best thing to do is bring awareness and education anywhere you can and any time. The more people that know, the more that can prevent future reactions from taking place. Conclusion. In conclusion, food allergies need more recognition as being a real thing. Millions of people are suffering every day from food allergies, and this issue is only becoming worse. If the House of Representatives pass this bill, hopefully allergic reactions will decrease among the globe. The more awareness we bring to this topic, the better. Granted, awareness is not a cure, but it still can be a lifesaver. And this is my references. Thank you.